3, 2, 1. Please start. We are live now.
Good evening, everyone. I welcome you all for today's webinar on oncology cancer treatment updates. With immense pleasure, I would like to invite Dr. Sumit Goel, who is the Associate Director, Medical Oncology, RGCI Delhi, for the welcome and introductory note. The stage is all yours, sir.
Good evening, everyone. Thank you very much for giving me this opportunity today to have another wonderful session of interaction and learning. So today we have topics on lung cancer, and we will be talking about the pathology aspects and the treatment aspects, especially in the EGFR mutated lung cancer. And also we will be having a session on nutrition in oncology. So not taking much of time. So may I request Dr. Sunil Pasricha? He is a senior consultant at Department of Pathology at Rajiv Gandhi Cancer Institute. He is a dear friend and a colleague and a wonderful pathologist. He has a vast knowledge. And Dr. Pasricha, if you are there, can we have your presentation? Hello, Dr. Sunil. So Dr. Sunil will be talking on biomarkers in the management of non-small cell lung cancer. So we know biomarkers are becoming very important in day-to-day practice, whether it's PDL1 or it is other markers like the EGFR, ELK, ROS, and so on.
Sorry to interrupt. I guess there is a network issue from Dr. Sunil. He is rejoining in a minute.
So, yeah, I want to know, am I audible?
Yes, sir. You are completely audible now.
Okay, so I'll just share my slides. So my slide is visible.
Yes, sir.
Just a second. So, I think it's not moving.
Mahima, do we have sir?
Yeah, so is it moving now?
Yes, sir. It's moving. It's moving.
Okay, so good evening, everyone. So thank you, Dr. Sumit, for the kind introduction. So I'll be starting with my presentation of predictive biomarkers in metastatic NSCLC. So as we know that tissue is always the issue. So the endoscopist or the radiologist, they should be encouraged to perform multiple sampling. Ideally, 5 cores should be sampled, and pathologists should manage these cores wisely and judiciously. So we have to actually economize on the use of the tissue. Each core of the tissue has to be blocked separately, and the initial diagnosis to be completed using 4 sections. We have to actually rely on morphology and limited immunohistochemistry. And as far as possible, we have to go for upfront or reflex molecular testing for the specified markers. And why it is important? Because the appropriate number of the tissue sections they are cut at the first time. There is no repeated trimming of the blocks, and there is or any wastage of the tissue. Just a second. So that there is no repeated trimming of the block or the wastage of the tissue, and moreover, the turnaround time is also controlled. So Coming to the driver mutations in the NSCLC, we know that more than 90% of the lung cancer, they are basically they are non-small cell lung cancer, and majority of them are adenocarcinoma. And the role of pathologists in this current era is not only just to diagnose a lung cancer, but also to find out the various predictive biomarkers so that the patient can be put on the targeted therapy. And why it is important, and this is being highlighted in the Lung Cancer Mutation Consortium, so which analyzed 733 patients for the 10 genes. And we can see on the right side in the graph that when the patient were put on the targeted therapy, when the targets were available in the form of predicted biomarkers, so the orange curve is showing that the survival was very good as compared to when the patients were not put on the targeted therapy or when the no drivers were identified. So we can see there is a good prognostic separation of the curves when the patient were put on the targeted therapy or when they were not put on the targeted therapy. And the consortium demonstrate that the best outcomes were seen in the patients with the identified drivers which are placed on targeted therapy with a 3.5-year median survival. But there is also potential application in the uncommon mutation beyond EGFR and ALK, like ROS, RET, BRAF, B2. And so in all, they makes around 15% in all. And majority of these common and uncommon driver mutations, they are targetable with FDA approved agent, or they can be in the clinical trials. Like recently, we have seen EGFR exon insertion, the drug, the amivantamab, and has been approved, and mobocertinib has been approved. And for HER2, trastuzumab deruxtecan has been approved. And for the KRAS, sotorasib and adagrasib has been approved. So there has been an evolution of the therapy in the lung cancer, and we have realized over the last 1 decade that it is not a single disease, but it's a spectrum of many diseases. So biomarker testing in the lung cancer is always being a moving target. If you see in 2013, guidelines were there to test for EGFR ALK fusions, and there was insufficient evidence to support NGS panels, whereas in 2018 updated guidelines, besides EGFR and ALK gene fusion, there was a recommendation to go for ROS1 gene rearrangement, and also to add BRAF, B2, MET, RET if doing a large panel. And very important, NGS panels were preferred over single gene test if you are going beyond EGFR, ALK and ROS. So the use of cell-free DNA, that is the plasma, for testing when the tissue was unavailable. And ASCO NCCN guidelines extended the recommendations to include the routine first-line BRAF mutation testing. So in a nutshell, we have 2 categories. One is the minimum necessary, which is must-do test, and other is the recommended category, which is should-do test, which we should do. Starting with the EGFR mutation, it's the most robust predictive biomarker for the response to EGFR TKIs, and it confers a more favorable prognosis, and therefore a targeted therapy should be used ahead of chemotherapy and immunotherapy in EGFR positive NSCLCs. In Asian population, especially adenocarcinoma, up to 60% of incidence, especially among the non-smoker females, has been found, and therefore a great efforts has been made to standardize these diagnostic tests. Approximately 90% of the EGFR mutations, they consist of either deletion in exon 19 or a single specific point mutation, that is L858R in exon 21. 2 FDA approved test kits are available. We are having at RGCI in our department. So one is a COBAS EGFR mutation test, and other is a COBAS EGFR mutation test V2 for T790M mutation. The other platform is a QIAGEN TheraScreen. So these tests are highly sensitive and can detect mutation in samples with tumor infiltration as low as 10 to 20%. But unfortunately, we know that resistance to these TKIs are inevitable. And these are the mechanism of resistance post first-line EGFR TKIs. And this resistance is attributed the major phenomena is the T790M, which accounts for 50% of the cases, for which the drug osimertinib has been approved, and also it has now been approved in the first line. And the other mechanisms can be like HER2 amplification, BRAF, MET amplification, PIK3CA mutations. So here comes the role of the liquid biopsy. Several studies support the use of plasma genotyping as the first line testing to detect T790M. The tissue biopsy would be required only when T790M is not detected in the plasma, as false negative rate of 30% is associated with plasma genotyping. But very important that the treatment response to tissue or plasma detected sensitizing mutation is exactly the same. The recommended and established use of first-line osimertinib may largely prevent the development of T790M resistance and has a much better CNS penetration. Coming to the ALK rearrangement, so more than 12 different variants of EML for ALK variants and non-EML fusion genes have been detected. The impact of these ALK variants on heterogeneity of the response to ALK inhibitor has not been fully elucidated till now. They are seen in 5 to 8% of the patients with advanced or metastatic NSCLC and commonly seen in young and non-smokers. So studies have shown the superiority of ALK inhibitors over chemotherapy in terms of progression-free survival and overall response rate. And the next generation agents like alectinib, brigatinib yielded a better response intracranially than crizotinib in terms of objective response rate as well as from time to CNS progression. Coming to the methods of identification. So these are the, when you're going for a single gene immunohistochemistry FISH, but as a part of a multi-gene assay, NGS is preferred. This is the basically mechanism of the ALK break apart. So what we do is that we put one probe at the ALK gene and the other probe is just adjacent to the ALK gene. So if there is a rearrangement or ALK fusion, so what will happen? We will see a rearrangement so that these signals will be distant apart, at least 2 times the diameter of the signal. When there is no rearrangement, we will see these 2 signals close to each other, touching with each other. So this is a negative test wild type and this is a rearrangement. In the immunohistochemistry, so this is showing us a positive test, showing a strong intensity in the upper slide, while the lower slide is showing a moderate intensity. Both are positive, but we have to take a positive and a negative control. Immunohistochemistry has a definitely advantages that it's a faster, cheaper, the standardization is easier, more laboratories can do it. It's reliable also as there is no false positive result because the normal lung tissue do not express ALK. And D5F3, the monoclonal antibody used on the Ventana platform, which has been FDA approved as a companion diagnostic. Superiority of the TKI crizotinib over chemotherapy was established long back in 2014. However, the resistance to treatment invariably develops, often with the progression in the brain. So the role of second generation and third generation TKIs, that is brigatinib, ceritinib, alectinib, and the third generation lorlatinib have proven their much better efficacy. Especially the third generation lorlatinib has led to 72% improvement in the PFS as compared with the crizotinib in the first line treatment. Now the ROS oncogene is a receptor tyrosine kinase. It is the rearrangement is seen in 1 to 2% of the NSCLC and it occurs due to translocation between the ROS1 and the other genes. The most commonly is the CD74 and it leads to the activation of the downstream oncogenic pathway. And it is also sensitive to the ROS1 inhibitor like crizotinib and entrectinib, which are FDA approved for the patient who are treatment naive or post chemotherapy. In the methods of detection, the FISH is recommended as a single gene assay and NGS as a recommended as a part of multi-gene assay. Immunohistochemistry is very effective way of screening and we are doing it at RGCI. So D4, D6 antibody from cell signaling is recommended antibody and another now recently introduced antibody just a year back, that is SP384 from Ventana, is also recommended and has shown good results. But the bottom line is that all the positive immunohistochemistry cases must be confirmed with the FISH analysis before starting on the targeted therapy. So unlike ALK, where the IC is confirmatory, for ROS1, the immunohistochemistry is for the screening, not a confirmatory. So this was the case showing a micropapillary pattern of growth and showed a strong ROS1 diffuse expression, which was subsequently confirmed on the FISH. Coming to the BRAF mutation, it's a downstream signaling mediator of KRAS that activates the MAP kinase pathway, and the mutations are seen in 1 to 3%. The mutation can occur at the V600 position of exon 15 or outside the domain. And NSCLC patient who progressed on chemotherapy, the combination of the BRAF and MEK inhibitors, that is the dabrafenib and trametinib, has been approved by FDA. Again, the testing method is the PCR sequencing when you're going for a single gene or NGS as a part of multi-gene assays. So these are the trials, initial trials, which have shown a good response to the dabrafenib plus trametinib could represent a new targeted therapy with robust anti-tumor activity and a manageable safety profile in the patient with previously treated or untreated BRAF mutant NSCLC. Coming to the recommended or the should do test. Most important is the MET exon 14 skipping mutation or amplification. So this causes a dysregulation of the MET pathway. So basically MET is a proto-oncogene that actually encodes the tyrosine kinase receptor for the ligand is a hepatocyte growth factor. So here in the figure, we can see that so if the exon 14 is the splicing abnormality is there and exon 14 is skipped in the messenger RNA transcript. So that leads to the formation of the truncated protein, the MET receptor, in which there is a absence of the protein Y1003, which is required to bind with the CCLB for ubiquitination proteasome degradation pathway. This is the normal phenomena. We can see that upon MET activation, and so that leads to the cell proliferation, survival, and transformation. But at the same time, there is a regulation, like this protein binds with the CBL site of the ubiquitination proteasome pathway, and that leads to the regulation also of this, so that it is not constitutively activated. But when there is a mutation, this regulation goes away. So now what happens? There is a constitutive activation of the pathway, which will lead to tumorogenesis. So when to anticipate? So if you have a sarcomatous differentiation, a tumor which is showing a cytokeratin positive but negative for TTF and P40, showing a carcinosarcomatous differentiation, this morphological pattern may warrant a upfront MET gene testing. Coming to the characteristic of the MET exon skipping mutation, so they are seen in 3 to 4% of all the metastatic NSCLC. They can be associated with MET amplification, copy number variants, commonly seen in females, the elderly especially, and the non-smokers, but highly predictive of response to MET inhibitors. The FDA have approved capmatinib and tepotinib for metastatic NSCLC whose tumors have a mutation MET exon 14 skipping, which is detected by a FDA approved test. And also MET exon 14 is an independent indicator of poor prognosis and shorter overall survival, which was established long back. And we can see on these the Kaplan-Meier survival curve for the overall survival, there is a prognostic separation of the curves when there was a MET exon 14 skipping mutation as compared to the wild type. So FDA has approved the Foundation 1 companion diagnostic to aid in the detection of the MET exon 14 in the tumor tissue. But recently we have realized that RNA-based sequencing is much preferred over the DNA-based NGS because the RNA sequencing has advantage of encompassing all the causal genomic events that lead to exon 14 skipping and hence being more sensitive. RNA sequencing detects the fusion of exon 13 to 15. So it's in the messenger RNA. So in one study, approximately 60% of the RNA positive results were found to be false negative in the DNA analysis that was published in JTO. So let me explain it diagrammatically. So this is a normal mRNA. So it has a number of base pairs. So here the exon 14 is intact. But what happens when there is an exon 14 skipping? So what will happen? The reading will be done. So n minus 140 base pairs, because 140 base pairs are attributed to exon 14. MET amplification is also a mechanism for a MET dysregulation. The amplification is regarded as a primary driver gene and also one of the main mechanism of EGFR TKI resistance. Depending upon the assay and the positivity cutoff point used, the occurrence of de novo MET amplification is approximately 1 to 6% in lung cancer, and many studies have associated the MET amplification with overall survival. The high amplification, that is a MET to CEP7 ratio of more than 5, that appears to be the strongest predictor of a true MET-driven tumor, which is seen in less than 1% of lung adenocarcinoma. It is also associated with a poor survival in NSCLC patient, and studies have shown the associated MET amplification with shorter survival. So MET is also a co-driver in NSCLC. MET amplification in EGFR mutant NSCLC comprises of 5 to 15% of the EGFR mutated tumors that have acquired resistance to TKIs. And liquid biopsy might be a very important tool to use in this situation to detect the secondary mutations without repeat biopsy and discomfort. And now with osimertinib as a first line of choice, the spectrum and association of MET mutation will remain to be seen in near future. The HER2 mutations, HER2 is a EGFR family receptor tyrosine kinase, and it is seen in 1 to 4% of NSCLC tumors, common in non-smoker females. Majority are in-frame insertion in exon 20, and few cases have shown point mutation in exon 20. They are detected using PCR or NGS. And early phase clinical trials suggest that the patient with the tumor harboring HER2 mutation who progressed on chemotherapy may respond to trastuzumab-based regime. And trials demonstrate no benefit for the trastuzumab for HER2 amplification. Coming to the RET rearrangement, the RET gene encodes for the cell surface tyrosine kinase receptor. The RET rearrangements are identified in 1 to 2% of lung adenocarcinoma, specifically seen in young and never smokers, and testing method, again, the NGS are recommended. And FDA has approved selpercatinib and pralsetinib for metastatic RET fusion positive NSCLC, and encouraging results were seen in the multi-cohort open label phase 1 to Libretto 001 study. NTRK fusion, the prevalence is around 1% in NSCLC. Larotrectinib and entrectinib are the two FDA-approved oral TRK inhibitors that has been approved actually in a tissue-agnostic fashion. And recommended method, again, the NGS as a part of multi-gene assay and FISH as a single gene. There is a IC we have at our institute and our department, the clone EPR 17341, which is used for screening only, and it shows a diffuse strong cytoplasmic staining. However, it has to be confirmed with the FISH or NGS. And standalone tests are not effective or feasible. The efficacy of larotrectinib has been shown in early phase clinical trials, and of the 12 patients with the lung tumor, the 9 experienced a response to treatment with a response rate of 75%. Into the NRG1 fusion. So fusion involving the neuregulin 1 gene are rare with the less than 1% prevalence. Again, the recommended method is NGS, and the data has suggested poor activity of chemotherapy and immunotherapy in this NRG1 fusion cancer. And in the case series of 5 patients who received imatinib therapy for NRG1 positive lung cancer, they demonstrated 4 partial radiological response in 5 patients, with 3 of these lasting over 18 months. The other targeted therapeutic against the NRG1 fusion are in the clinical trial development, such as seribentumab. Lastly, the RAS mutations, the activating KRAS mutation, which activate a number of downstream signaling pathways, they are actually observed in approximately 25% of lung adenocarcinoma. The recommended method again is the NGS as a part of multi-gene assay. Multiple agents specifically targeting the KRAS G12C mutations, which is seen in which is comprising of 50% of the KRAS mutation in SCLC, have emerged. And sotorasib is approved by FDA for KRAS G12C mutated, locally advanced or metastatic NSCLC, provided who have received at least 1 prior systemic therapy. So in a nutshell, NGS is now preferred over a single gene assay, and that's a reason that it's a tissue proficient 10 nanogram input of DNA and RNA is sufficient. It is resource proficient. It's a 1 experiment, 1 platform. The variant allele detection cutoff is around 5%. Hence, it overcomes the problem of the low tumor fraction. And it helps to detect the tier 1, tier 2, and tier 3 alteration. And depending upon that, subsequently patient receives the targeted therapy or can be subsequently recruited in the clinical trials also. And NGS can also use plasma as a sample, and there is a FDA approval for the analytical, clinical, and clinical utility. However, a TAT is still a problem with that. Coming lastly to the biomarkers for immunotherapy, as of now, there is no robust biomarker, but work is still in progress. And these are the various biomarkers at our disposal. And out of all these biomarkers like MSI, TMB, gene expression signature, and PDL1, it is a PDL1 IC that has emerged with a good passable utility, which is a therapy-specific biomarker. So what is the indication of immunotherapy in NSCLC? It is the metastatic NSCLC for the first line and second line or the later line treatment, and also for the locally advanced stage 3 NSCLC as in the form of consolidation treatment, where we are using durvalumab. So the utility of, the indication of the monotherapy pembrolizumab was established 3-4 years back. So if the PDL expression is more than 50%, irrespective of whether the morphology is adenocarcinoma, squamous cell carcinoma, and if it is a NOS, so pembrolizumab monotherapy as a first line was established. And these are the current recommendations for immunotherapy for the first line. If the TPS is more than 50%, it's the pembrolizumab monotherapy. But if the TPS is less than 50%, pembrolizumab is approved in combination with chemotherapy. For the second or the later line, pembrolizumab is approved for TPS more than 1% and nivolumab for any TPS. So for nivolumab, it is not recommended to go for the PDL1 testing. However, nivolumab in combination with the ipilimumab has been approved as a first-line treatment for metastatic NSCLC expressing PDL1 more than 1%. These are the two most common assays which are used. One is the PDL1 for the 22C3 Pharma DX, and which is the FDA approved and also CE marked, while the other is the Ventana PDL1, that is SP263, which is done on Ventana Benchmark Ultra, and which is European conformity marked. And in our experience, we have seen that, and recently in the blueprint studies, it was shown that they are at par, but we have realized with our experience that the SP263 stains more number of tumor cells and has a chances of giving you a false positive. And we have done the project and we have submitted it for publication also. So what we are doing now is a lab developed test in which we are using the 22C3 clone on Ventana platform, and we have validated it and it is working very nice. PDL1 IC testing is an established predictive biomarker for immune checkpoint inhibitor in NSCLC. Although it is not a robust biomarker, but it is still the best we have. To conclude, there is an extensive role of biomarker testing in metastatic or advanced NSCLC adenocarcinoma. The broad molecular testing, NGS and liquid biopsy have already made their place for biomarker assays. Multidisciplinary communication is essential for the quality information within the required time frame to maintain the turnaround time, and that too at the judicious cost. And it's incumbent upon pathologists to make the testing reliable by optimizing the pre-analytical, analytical, and post-analytical steps. Thank you so much.
Thank you, Dr. Sunil. That was a wonderful presentation. And thanks for giving us insight and nuances of molecular testing in lung cancer. So one question always remains, that is which test to send when we are at a place which is like far from a metro and we want to give appropriate treatment. And even if we are in a metro, which is the like quickest test we should do so that we have important information so as to start the treatment in today's scenario in metastatic lung cancer.
So I think if suppose it depends upon the probability, like if the patient is a non-smoker, if she's a non-smoker female, the pattern is a lipidic or a acinar pattern. So there is a good anticipation, or if there is that a EGFR can come positive. So in that case, a single gene assay, like one can go for a EGFR by a PCR based, or what we are following at RGCI is that we are using a smart lung panel. So what we are doing here is that the cost is minimized, but it still takes into account 32 genes in the NGS. And what we are doing here is that we are doing EGFR by PCR and ALK by immunohistochemistry. So what happens is that within 2-3 days we are ready with the, within a single day we are ready with the ALK report, and we are in 3-4 days we are ready with the EGFR report. So that takes care of around probability of 30 to 40% of the targeted biomarkers that can be detected, and subsequently the smart lung panel, the NGS, gives the other rare mutations that can be detected.
Thank you, Dr. Sunil. That was a thank you very much. So I think if we have some other questions, we will ask at the end, sir. Thank you very much, Dr.
Thank you
for your presentation.
Yeah, thanks.
If someone has any other query or question for Dr. Sunil, we can have it now or later also, or we can put it in the chat box also. So moving on, I think next session is on nutrition, role of protein supplement in cancer therapy. So I will be talking very briefly about it. So if I have the permission to share the slides, just so hope my slides are visible and I'm audible. So I'll be just very briefly talking about role of nutrition and protein supplements in cancer patients. It's very important. So malnutrition and loss of muscle mass are frequent in cancer patients and have a negative effect on clinical outcome, driven by inadequate food intake, decreased physical activity, and catabolic metabolic derangements. Therefore, we need to have a standard procedures and responsibilities and good quality control process that should be established at each institution who is involved in giving cancer care. So, so we know there's a huge burden of cancer globally. As per latest global cancer data, the cancer has risen tremendously. The new cases, there is almost there were about 50% deaths in 2018. So not going into the details, we know both the incidence is on increase, more so in the developed countries. So if we look at the incidence of new cases, Uh, of Indian data, it was close to about 1.15 million cases were there, which were diagnosed in 2018. If we look at the mortality, approximately 70% of the patients died who were diagnosed. So it is a huge burden. And malnutrition has a very important role to play in cancer, both in terms of treatment, morbidity, and outcomes. So we know the patients with cancer, they have altered nutritional status at presentation, and it varies through the continuum of cancer care. So most of the patients, they experience unplanned weight loss, leading to diagnosis of cancer. In GI malignancies, it is very true. Usually the main presenting feature sometimes is weight loss. And approximately 30 to 35% of the patients, as per this report published, they had malnutrition when they were diagnosed with cancer. At some point of time, they had cancer, they had malnutrition, which at times go unnoticed. If we look at the prevalence of malnutrition in different branches of medicine, so oncology has very high incidences. Again, this gastrointestinal or pancreatic or hepatopancreatobiliary GI malignancies, they have the higher incidences of having malnutrition. So there are metabolic changes which are happening in oncology patients. So it happens in two ways. One, cancer, it directly secretes the cytokines and cachectic factors, and it affects the brain, sends the signals to the brain to decrease the food intake, leading to anorexia. So the cytokines, the different cytokines that are secreted are either tumor necrosis factor or interleukins or interferons. So they'll cause increased lipolysis by acting on the fat. They increase nitrogen loss to the liver pathways, and in the muscle they causes insulin resistance. The interaction leads to either insulin resistance, decreased synthesis of proteins, increased breakdown, and skeletal muscle and fat mass wasting results. So, role of tumor-induced systemic inflammation with metabolic pathways in organs affected by cancer cachexia, we all know, is of it is of tremendous importance, and we need to recognize these factors. And to have better outcomes, we need to have good nutrition plans and programs in our armamentarium and the hospitals. So we know the patients which are being independently associated with malnutrition, in which there's more than 5% weight loss is there. One is colorectal cancer, hematological, maybe directly or indirectly, and head and neck cancer also we because of the difficulty in swallowing, or they are associated with weight loss and malnutrition. So there are many causes of malnutrition in oncology setup. It may be there at the time of diagnosis. It may be there when the treatment is going on, but it may be after the treatment has started. So before or at the time of diagnosis, it may be social factors like availability of food, place of stay, poverty, then personal preferences about the food, food fads. People don't, they are sometimes fussy about the food, then depression, old age, and other factors like tobacco use and so on. There are many factors which are associated at the time or before the time of diagnosis. Then in the hospital, it may be related to disease per se or related to the treatment also. Or it may be because of the effects of the chemotherapy like fever, sepsis, surgery, trauma, medication, sedation, GI problems, which may cause malnutrition. Then again, investigations, appetite, food choices, there are multiple factors. So after again, once the treatment is over, the patients may have dietary or nutritional deficiencies because of that, either depression, they don't know, they don't have adequate advice, there is no supervision, they feel depressed or lonely. So it significantly increases the cost, mortality, morbidity, and the effectiveness. So if we look at the cachexia or malnutrition. So it is there. So it starts with pre-cachexia, cachexia to refractory, and in sometimes it may contribute to increased death rates to the tune of 20%. So as stated earlier, 1 in 5 patients with cancer may have cancer cachexia. So the nutritional problems of underlying patients undergoing radiation and chemotherapy, though there is a good overlap, but it varies. Like in radiation patients, one of the more important causes is mucositis or aversion to the food or taste alteration. It may be because of radiotherapy effects. Then in chemotherapy, it is basically because of the reduced appetite or mucositis or the taste loss or loss of the sensation. So we know all this leads to the muscle depletion, which is associated with weakness and fatigue, but also with increased risk of toxicity from the different regimes. So there is data which says if the patient becomes sarcopenic, the toxicity is much more, as shown in this chart. Whatever be the chemotherapy regime patient is receiving, if the patient is malnutrited or is sarcopenic, there is increased risk of toxicity. So then there is again non-nutritional risk factors in the cancer, which can lead to malnutrition, which can be like immune suppression, mucositis, then the treatment lasts for several months. So there is a dynamic relationship of nutritional depletion and cancer treatment. On one side is the malnutrition, which may be the effect of the cancer or effect of the treatment, uh, but it is an important aspect which can also hamper the toxicities. And so in the treatment of the cancer, the supportive care, the care of nutritional supplementation forms one of the very important aspects. So nutritional support, either it may be oral nutritional supplements, it may be enteral or parental. So we know nutrition is integral part of the cancer treatment of for supportive care. So the nutritional therapies, I said earlier, it may be oral dietary therapy, it may be enteral, which is the most preferred ones. Parental, sometimes we do have to rely on parental therapies, and we have to go for oral dietary therapies. So we know the importance of protein supplements, sources of proteins. We can skip this. So enteral nutrition, we know it is a feeding solutions to the tubes into the digestive tract. We do need it in patients who are head and neck cancer patients going treatment, either radiation or who have dysphagia, then esophageal or GI malignancies. Then we need to bypass the system so that we can deliver the nutrition directly to the GI tract. So the recommended calorie and protein intake for the cancer patients, the calorie requirement is 25 to 35 kilocalorie per kg per day, of which lipid, glucose, carbohydrates should come from less than 5 grams per kg per day, and the protein requirements is 1.5 to 2 grams of proteins per kg per day. So enteral or parental nutrition, both are having advantages and disadvantages. The in real time practice, both should be complementary to each other and not competitive. We mostly prefer enteral, but wherever required, parental is equally important. Then again, at hospital we do manage. Then there is equally important aspect which we need to look at when once the patient is at home. So nutritional therapy in oncology, it is a evolving supportive care to anti-cancer treatment. So we need to correct risk like that of malnutrition, preservation of muscle mass and function, which can also affect the dose limiting toxicity and even have modulation of pharmacological and physiological effects of treatment. So goals of oncology specific nutrition is to maintain or increase body weight, preserve reduce inflammation, improve immunity, and to improve the tolerance to multiple cancer. Ideally, high protein, high energy, especially lipid-based therapy should be the baseline. So these interventions, we know if the interventions are done at right time, there are less number of breaks and the better outcomes. So we know the prophylactic PET tube insertion in head neck cancer patient has improved outcomes. So a role of nutrition in head and neck malignancies and other GI malignancies is of paramount importance. So I will not go into the details of this. So in all the malignancies, the nutrition plays an important role both in defining the outcomes and preventing the toxicity. So micronutrients are equally important. So if we look at the SPEN guidelines, so the guidelines say that the total energy expenditure of cancer patients, if not measured individually, be assumed to similar to healthy subjects, generally ranging between 25 to 30 kilocalorie per kg per day. And the protein intake should be around 1 to 1.5 gram per kg per day, and possibly on the higher side. In weight losing patients who have cancer and with insulin resistance, the ratio of fat to carbohydrate calories should be increased. Then vitamins and the trace elements. So the diet, as we know, when we say balanced, it should have adequate micronutrients also. So it calls for action to provide improved nutritional care for patients with cancer, regardless of BMI or weight history. We need to improve the nutrition, and the each nutritional intervention needs to be individualized. Most of the time, it is not possible, and we rely on formulas which are like for for everyone. So, in the nutshell, we know malnutrition in oncology is a problem, and oncology patients are at high risk of malnutrition, even when once they are diagnosed, during the treatment, or even after the treatment. And the nutritional treatments treatment started early not only helps in completing the treatments and improving the outcomes, indirectly it definitely affects our financial implications also. So we have nutritional strategies like to modulate or reduce the anorexia, to improve the quality of life by giving early nutritional supplements, and improving the outcomes in nutshell. So I'll stop here. Thank you very much for your kind patience listening. So if there are any questions, we can take them now or later.
Yes, sir. Hello, sir. Am I audible?
Yes, yes.
Yes, I'm Dr. Kupil Goyal here, sir, from Action Cancer Hospital. Sir, actually, I was wondering, actually, there was a lot of talk about role of antioxidants like glutathione and glutamine for prevention of oral mucositis or to reduce chemotoxicity, and somehow it makes part of nutrition only, like vitamin supplement or some glutathione supplement. So, what do you feel about? Does it provide any clinical advantage, and what is your practice?
See, there are two things. One is my practice, one is the guidelines. So if we do the Google search, simple Google search, antioxidants and chemotherapy, the first thing that comes into all the data that it pulls out is it reduces the efficacy of the chemotherapy and and radiation therapy, because we know radiation works on the principle of oxidation, and giving the high doses of antioxidant therapies, usually I am skeptical, and in my practice I usually do not use much of antioxidants while during the treatment. So once the active treatment is over, then I do not know, but I really use it later and judiciously. And during the course of like radiation therapy, as you said, mucositis, I try to handle it by uh, sportive and symptomatic measures. I, glutathione and all I hardly use, and curcumin definitely I don't use.
Okay, thank you so much, sir. That's all.
So if there are no more questions, I think we will move on to the next topic. The next topic is real-world experience of osimertinib in the treatment of EGFR-mediated non-small cell lung cancer. which is to be presented by Dr. Niti ma'am. Ma'am needs no introduction. She is director at Fortis Hospitals in Bangalore. She is the director and head of the Hematology and Transplant Division also. So, Dr. Niti ma'am, over to you for your talk.
Thanks, Dr. Sumit. Thanks for inviting me today. Good evening to one and all. I sincerely thank the organizers as well for remembering me for this talk. I think I'll be talking about a much discussed topic. We have been talking about this for over years, but I would like to emphasize here on the real world evidence for osimertinib as the standard of care in the first line management of NSCLC patients who express EGFR mutations. Are my slides seen, Dr. Sumit?
Yes, ma'am. Slides are visible and you are audible.
Okay. So as we all know that EGFR mutations, as the first speaker rightly said, is one of the most common mutations when we see an Asian ethnicity woman who's a non-smoker. And we have enough data to suggest that first-line use of EGFR TKIs are the standard of choice when we compare with cytotoxic drugs. And here too, the third generation EGFR TKI, osimertinib, which is an irreversible third generation TKI, has found to have demonstrable clinically meaningful improvement in the median progression-free survival and also the overall survival. And the median overall survival has been remarkable on the use of osimertinib. That's about 39 months. So we have this evidence with the FLORA data. All of us have known it for years now. And final overall analysis suggested use of osimertinib as a single agent in the first line setting in the dose of 80 milligram once a day dosage. FLORA was a double-blind study, multicentric study in which 1:1 randomization was done between osimertinib arm and that time comparator arm, that was geftinib and erlotinib, in patients who were 18 years and above, who were in good performance status, who had exon 19 deletion or L858R noted in central testing or local testing, who had not received any prior anti-neoplastic therapy, and of course not received an a TKI therapy as well. And all these patients had stable CNS disease. Baseline characteristics were matched between the comparator arm, that is geftinib erlotinib arm, versus the osimertinib arm. So PFS was in favor of osimertinib arm in all the arms, whether it was comparing the gender, when higher age group versus lower age group was compared, non-Asians versus Asians, smokers versus non-smokers, and of course, patients who had baseline CNS metastasis with good performance status, whether it was exon 19 deletion or L858R, or whether it was centrally tested or locally tested. Again, the final analysis of overall survival again suggested that the median overall survival was 39 months, which was 32 months in the comparator arm. So there was a difference of about 7 months noted, which was again very remarkable in terms of hazard ratio, which was 0.79. So the overall survival of FLORA reinforced use of osimertinib in the standard of line, first line treatment settings in mutated EGFR NSCLC patient. And therefore, this remains the NCCN guidelines at this juncture. Moving on to 3 important studies which I want to discuss here. One is the FLOWER study, one is the OC-FACT study, and the last one is the MYCO-NOS study, which again discusses the real world evidence. The first study is FLOWER study, which was a single arm study in which the median age of patient was 68 years, which was almost the same as FLORA study. Brain metastases were present in 31% of this, which was much higher than the FLORA study. 69% had no brain metastasis at baseline, but some of them had subsequent brain metastasis. The stage of diagnosis primarily was stage 4A and 4B. That is almost 95% patients were stage 4. Most of them were in good ECOG performance status, that is 87%. And the inclusion criteria was again confirmed NSCLC, who had exon 18 to 21. So it included all sensitizing and non-sensitizing mutation as well, with stage 3B and above, as per the AJCC 8 staging. And all these patients had not received any prior treatment, and first line received osimertinib. What was noted was median, this was the interesting parameter which was studied, that is time to deterioration. Median time to deterioration remained the primary point of analysis, which measured the time of osimertinib start to discontinuation due to any cause. Now, this cause could be treatment-related adverse event, whether dose reduction was required, which required temporary or permanent discontinuation. So TTD remained the exploratory analysis in this, and later on now has become a good real-world endpoint in most of the studies as well. The secondary endpoint was median overall survival, median progression-free survival, ORR, DCR, that is disease control rate, and diagnostic therapeutic pathway remained what we discussed, biopsy, IHC, and then confirmation of EGFR. So when we saw the primary assessment effectiveness, we found that patients with poor PS, with comorbidities, rare EGFR, and with active brain metastasis also were included. And all these actually also responded better with osimertinib. There was no difference in PFS, time to deterioration, and OS noted in elderly patients or patients with comorbidity or patients with less common EGFR mutations as well. So these were the Kaplan-Meier curves noted for osimertinib in real-world data. And as I said, there was no difference noted in any subset. So TTD appeared to be a more suitable endpoint to evaluate the treatment outcomes in real-world trials. TTD was longer, that is about 25.5 months, than the post-progression outcome analysis of FLORA, which was only about 21 months. This was kind of a very interesting point noted. Better TTD was associated with fewer than 3 progressing sites and isolated progression. Now, why was this? The reason is that some patients would actually have had a radiological progression. But since there was no symptomatic progression, they were continued on this drug. And so time to deterioration was still noted as that they did not have any symptoms and they did not have any symptomatic deterioration. And so these patients were continued to be included in this trial. These are the subset analysis, all of which favored osimertinib arm, whether patient had brain metastasis or liver metastasis. CR rate were not noted surprisingly, but PR rates were in the tune of 73%. Stable disease was about 23%, and only about 4% had progressive disease. All the safety analysis was the same as noted in FLORA, and most of them had many only grade 1 and grade 2 toxicity, which did not lead to any discontinuation of treatment. There were some cases of venous thromboembolism noted, and almost 9.5% had all grade of venous thromboembolism, although grade 3, grade 4 were noted again in about 8%, so which was slightly higher than what was noted in FLORA trial. And this venous thromboembolism was not, had no difference based on age, performance status, comorbidity, and tumor load. Although clinically we would think that it would be, thromboembolism will be higher in higher age group who are less mobile with higher tumor overload. Talking about the second real world setting data, that is OC-FACT data. Again, this study was investigated the difference in efficacy with patient background and safety of first-line osimertinib in the real-world setting. All the patients with EGFR positive NSCLC were included who were treated with osimertinib in the first line. They should have not undergone any post-op adjuvant chemotherapy as well, and no TKI should have been exposed in the past. They should not have undergone any thoracic radiotherapy as well in the prior setting. Interestingly, in this mutation, that is whether they had 19 deletion or L858R was noted, whether they had recurrent tumor or stage 4 tumor was noted, and PDL1 was also assessed in all the patients and compared with the results. The primary endpoint was progression-free survival. And it was found that in the 5 38 patients who were analyzed. 182 events occurred with a median progression-free survival of about 20.5 months. And this progression-free survival depended on several factors. Male gender actually had a higher or a better PFS. Malignant effusions responded better. Liver metastasis had better response. Advanced unresectable cases again had higher response. And I would describe in detail what happened with the PD-L1 expression status. So median progression-free survival was not reached in the subset which had TPS score of less than 1% with PD-L1 expression. The median PFS was 14.7 months when the TPS was less than 49, that is 1 and 49%. It was 11 months when the TPS was higher than 50%. So higher the PD-L1 expression, poorer was the response. And this is what I mentioned, was stage, liver metastasis and malignant effusion. What was the reason of treatment discontinuation? Well, the most common reason was, of course, disease progression, noted in 45% cases. But again, a very surprising subset was 26% of patients who had treatment discontinuation because of pneumonitis. Now, this is not what we have recorded so often in other study, and especially not in FLORA. And then other 16% had very small, minor other adverse event, including anorexia, skin disorders. Some of them had QT prolongation and even cardiac failure. I'll just let this pass. Yeah. So pneumonitis, all grades were noticed in about 13% of individuals, and significant grade was also noted in quite a few. Hematological toxicity was noticed in only 4.3% of individuals. Non-hematological toxicity was seen in about 12%, and reduced ejection fraction was seen in 2% patients. So the ORR was about 76%. The disease control rate was about 94%. PFS was obviously in favor of osimertinib arm. Median TTF was 19 months, with median time to the start of treatment to the onset of adverse event was about 2 months. That is, the first adverse event on an average was noticed at 56 days. The third real-world study again had two very interesting parameters. It was actually a single-arm study in which demographic and clinical characterization of patients were also seen, and real-world NTD was noticed, which is real-world time to treatment discontinuation and real-world time to next treatment or death. So all the patients who received osimertinib in the first-line setting, it was a global observational prospective study, and it is actually currently ongoing in the United States, Europe, and Asia. In the US, Flatiron Health electronic medical records were taken for analysis of the US subset. In the US, almost 280 cities, that is 280 cancer clinics with 800 sites were enrolled. The recruitment period is from June 2020 to June 2023. That is exactly 3 years, in which advanced stage 3B to stage 4 NSCLC were taken, who had EGFR expression and initiated on first-line osimertinib. For assessment and statistical analysis, standard Kaplan-Meier analysis was done. The socio-demographic characteristics included age, the gender, race, whether they were Black, Afro-Americans, Asians, or whites. It was found out whether it was in the academic setting or the community setting, against typically in the United States, and what was the region in the United States in which patients were recruited. Clinical characteristics, again, were also recorded, including smoking history, ECOG performance status, Charlson comorbidity index for all the patients was recorded, metastatic sites, and evidence of liver metastasis. 548 patients were recruited, again, a very high number. And the most common exon noted was exon 19 deletion, which we also seen in practical setting. L858R was recorded in 34% patient, and both of them also had 0.7% prevalence, again, which is very unique. And there were certain uncommon mutations which are noted in about 10% patients. So at the interim analysis, 58% still remained on first-line osimertinib therapy. About 18% received second-line treatment. 18% died during the first-line treatment, and about 5% discontinued first-line treatment. The median follow-up was about 9.6 months. The median real-world time to next treatment or death was 17.9 months, with the events of death in 18% patients and 18% switched to second line. The real-world time to next treatment or death was also attached to multivariant analysis, which showed that smoking status, the Charlson comorbidity index of greater than 4, the type of EGFR mutation and number of metastatic sites had a significant relevance. This was also seen when we saw the real-world time to treatment discontinuation, in which again, the median real-world time to treatment discontinuation was 17.2 months, and it was related to all the 5 factors, which was mentioned previously as well. So what are the take-home messages? Well, this study does provide that there's real-world insight on the use of first-line osimertinib in patients with advanced EGFR positive NSCLC based on the first data cutoff analysis in the US subpopulation, although the data of other population is still awaited. The interim data supports the effectiveness of osimertinib. There is sub-analysis which shows that certain subgroups may not do as well, however, still remains the standard of choice. Thanks so much.
Thank you, Dr. Niti, for your wonderful presentation and showing us the data of real-world evidences. So we all know osimertinib is a very good medicine and definitely gives a long-term outcomes. So anything, ma'am, you want to highlight any particular point?
No, Dr. Sumit, we have enough data, I'm sure. And I think the only constraint possibly is sometimes financial constraint. And we don't have enough data to compare whether EGFR along with chemotherapy versus third generation TKI as a single agent, which one would be superior. But at this juncture, wherever feasible and based on the fitness and performance status, and if we have an EGFR mutation report early, then I think we would prefer to start osimertinib.
Thank you very much, Dr. Nithima, for your wonderful presentation and insights. So moving on, we have next topic. It is lung cancer management, focus on EGFR TKI. And it is, the speaker is Dr. Venkat Babu. He's a senior consultant and he's a dear colleague. He's a medical oncologist and working in Assam. He's doing a wonderful job there and serving the masses in an area in which the medical oncologists are dearly needed. So great job, Dr. Venkat. So over to you for your presentation.
Thank you, sir. Sumit, sir, for inviting me for this wonderful meeting. Am I audible, sir?
Yes, Dr. Venkat, you are audible.
Yes. Thank you, sir. I worked with Dr. Sumit Goel, sir, for a few years, and he has been my mentor and guide. And that experience is helping me actually in working in a resource limited setting, because even getting a lung biopsy is challenging in the area where I was working. Patient has to travel for 4 hours to get a lung biopsy, and then I have to coordinate with multiple calls to get the next generation sequencing done, so that patient will get targeted therapy if the patient is suitable. So without much ado, I will proceed with the topic allotted to me, that is the focus on EGFR TKI. But most of the important data which is relevant to practicing clinicians has been already covered. So my presentation will be mostly relevant to the first year postgraduate or second year postgraduate, if at all they are present here. So I request the organizers to project the slides onto the screen, please. Can you? Yeah, thank you. Next slide, please. We do know that lung cancer initially used to be most common cause of cancer as well as mortality. Now it dropped to third most common cancer in incidence, but it's still the most common cause of death. Because of its aggressive in nature, the two most common cancer in incidence are breast and prostate, which have very much sophisticated treatments and number of lines after the first line failures. So the survival is quite long in those cancers compared to lung cancer. Next slide, please. So Asia nearly contributes to 60% of the total burden of lung cancer across the globe. The reasons are many, and the most important factor is smoking. However, there are a number of cases who are non-smokers gradually increasing. When we see this graph where Asia occupies more than 50%, more than half of the burden of entire globe is being borne by Asia. Next slide, please. Yeah, we do know that gene alteration is cause of any cancer, for that matter. But in lung cancer, we have now a single gene-driven cancers as well as tumors with higher mutational burden, like in patients with smokers and other insults where there's a lot of mutational burden. The tumor is driven by multiple pathways and not a single pathway, where we can see and calculate the mutational burden TMB, which we sometimes use as a parameter to use immunotherapy. But there are some cancers that are caused and driven by a driver mutation such as EGFR, ALK, ROS, etc., which are clearly described by Dr. Sunil Pasricha in his talk. So this gene alteration as a cause of lung cancer, when it is identified as a driver, this can be targeted to control the cancer. And it is a very surprising fact to see that nearly 52% of lung cancer patients, they were non-smokers. And male to female ratio, the 3.5:1. Why this non-smoking lung cancer is much more common in males compared to females? The reason may be due to the exposure of environmental factor, which still needs to be elucidated. And this is the reason why International Association for Study of Lung Cancer, it has a huge scholarships for those who are studying on these factors, unrelated to smoking. And they have a wide area of scholarships for those students as well as researchers. Next slide, please. And when we see the survival in advanced lung cancer, it was seen that from the SEED database, approximately 60% of patients, even in those countries where smoking is relatively common and LDCT is very commonly available for screening, 60% of them are diagnosed in stage 4 lung cancer. And survival rate is only 4% at 5 years, which is very, very dismal. We can see here in this curve in the graph where the 5-year survival rate in stage 1 is 54%, which is very, very difficult to find a patient in stage 1 cancer, lung cancer. Next slide, please. So initially, we know that NSCLC 2 decades ago, it is considered as a one disease, and then came the histology basis subtyping as adenocarcinoma, squamous cell carcinoma, and other cancers. So squamous cell carcinoma is overtaken by adenocarcinoma at the beginning of this decade, and now it is the most common histological subtype. And adenocarcinoma is known to harbor most of the targetable mutations, and out of which EGFR is the most common targetable mutation as of now. In the future, it may be overtaken by KRAS, but as of now, it is the most common targetable alteration, followed by ALK. And we can see here squamous cell carcinoma can also harbor EGFR mutations along with some other pathways like fibroblast growth factor, etc. And it is very important to recognize that we need to send EGFR and other NGS also in squamous cell carcinoma, particularly in those patients with no smoking history as well as in Asian origin. Just like Niti ma'am has highlighted, it is important to search for targetable mutations. And there is a wonderful paper by Dr. Kumar Prabhash et al. And based on this publication, the recommendation to send NGS for targetable mutations in squamous cell cancers with particular factors has been included in NCCN also. Next slide, please. So when we see the targetable mutation in lung cancer, The most common is having no mutation. So it is a very common scenario that we send the NGS and we may not find any targetable mutation. And next common is KRAS, which is still to be targeted. There are drugs like sotorasib which are already approved but not available in India yet. The next most common is EGFR, occurs in nearly 23% of patients. Next slide, please. So in stage 4 non-small cell lung cancer, patients sending the patient's tissue for targetable alterations is very important. Previously, we used to check for the single gene alterations, and in some of the patients, we used to miss like other mutations like ROS, MET, etc. But now, because of the availability of NGS, even in remote areas, it is very common to send NGS limited hotspot panel for the lung cancer, and we are able to detect most of the patients who does have it. And overall survival of the patients, when we give the targeted therapy in those who are having the targeted alterations, they have much better quality of life in terms of less hospital visit, better efficacy, as well as the longer survival compared to the standard chemotherapy regimen. Next slide, please. And EGFR mutation, it is nearly 10% in Caucasians and 25 to 60% in Asians. 60% has been reported from the Asian countries like in China, where highest percentage of the EGFR mutation has been recorded. However, real world data anywhere varies between 25 to 40%. And in India, most of the studies, they reported more than 25% of EGFR mutation. Not only the primary EGFR mutations, but the resistant mutations like T790M after the challenge to the first generation TKIs, they're also relatively higher in Asian population compared to the non-Asian population. Next slide, please. So this is a pathway which any first year PG student should learn, because this EGFR pathway is a pivotal driver of malignancy, not only in lung, but also in other malignancies. This EGFR, that epidermal growth factor receptor, it binds to epidermal growth factor, that is the receptor, which has the 3 parts, that is placed along many of the membranes, including the skin, mucosa, as well as various cells such as alveoli. And next slide, please. The normal process is that whenever the growth factor, the epidermal growth factor comes and binds to the receptor, so there is a dimerization of the receptor, followed which there is a constitutive activation of the downstream receptors. However, when there is a mutation in the tyrosine kinase domain of the EGFR, this receptor, even without the presence of the growth factor, there is a constitutive dimerization and followed by the continuous activation of the downstream pathways, leading the cell cycle into a continuous vicious circle and proliferation, leading to the formation of the tumor mass. Next slide, please. So when we see the downstream pathways, we know that after the EGFR, it is the ROS, RAF, and then there will be JAK2 pathway that jumps into the nucleus and initiate the cycle-independent kinase activity. So these multiple pathways, cross-talking pathways, they will result in the proliferation, survival, angiogenesis, as well as inhibition of apoptosis. And we do know that these are the hallmarks of cancer, which are described by Hallberg and Weinberg and Hanahan, and this leads to the oncogenesis. Next slide, please. So this is the graphical representation of the EGFR receptor, and there are 3 parts to it. That is the extracellular domain, intracellular domain, and the transmembrane domain. And within the extracellular domain, there is a cysteine-rich domain, the importance of which will be later be discussed. And intracellular, within the intracellular domain, there are 2 important domains. The tyrosine kinase domain, which is represented in pink color here, it is coded by 4 exons of the DNA. So the 4 exons are 18, 19, 20, 21, out of which 19 and 21 are the most commonly altered exons, leading to the constitutive activation of the tyrosine kinase domain in the EGFR receptor. And this is the incidence that I have mentioned. And we can see here that exon 19 is the most common mutation, deletion of the exon 19, followed by exon 21 point mutation, that is L858R. And these are the two favorable mutations where the response to TKI from first generation to third generation has been excellent. Whereas exon 18 is relatively rare mutation with nearly 1% incidence. And the most common type is G799A or G719C. And exon 20 is the most resistant mutation with where T790M mutation can occur in 1 to 2% of cases, followed by other exon 20 mutations, which are also relatively resistant to the TKIs. But we should also remember when we are seeing the exon 20 in the NGS report, we should see whether it is EGFR mutation or HER2 mutation, because this is one mutation that can be present in both the genes. Next slide, please. So there are different generation of EGFR TKIs and their activity range widely differs. And we know that first generation TKIs are erlotinib and geftinib, and they are non-specific EGFR inhibitors. So they inhibit wild type EGFR as well as intrinsic, the EGFR mutant, and but their range is limited to only EGFR mutation. They cannot inhibit HER2 as well as HER3 mutation, HER3 receptors. Also, they are inactive against the T790M mutation. When we see the second generation TKIs like afatinib and decomatinib, they are irreversible covalently binding EGFR inhibitors where their activity ranges, and molecules like afatinib, they can act even in resistant mutations and uncommon mutations as well. They have broader activity, but at the same time, because of the broader activity, they have wide range of side effects and has become difficult to tolerate drugs as well. Coming to osimertinib, it is EGFR mutant specific inhibitors, which is that is the why this molecule is liked equally by patients as well as the physicians. Osimertinib does not have activity against wild type EGFR. That is the reason why it will not cause maximum amount of rash, which is seen in the first and second generation of TKIs. Also, the range of diarrhea is very less because of this specific activity against the mutant EGFR, but not the wild type EGFR. However, we should also note that it is not very much active against the HER2 and ERBB3. But it has very good activity against the T790M mutation. And this is the only molecule available as of now, which is active against T790M mutation. Not only it is active against T790M, but it also inhibits the generation of T790M clones when exposed upfront. Next slide, please. Yeah. So one of the most important challenge that is faced after using of TKIs is the honeymoon period of 9 months, where patients have very good quality of life. But as we proceed on to the 9 months to 12 months, most of the patients do have progression. And so it is seen that the benefit of PFS benefit that is seen with the first generation and second generation, they have plateaued after 9 to 14 months. And particularly from the period of IPAS trial, where we have seen that retrospectively that geftinib is very much effective in the EGFR population, followed by erlotinib and afatinib, and now decomatinib. The PFS does plateau after this 9 to 14 months. Next slide, please. Next slide, please. So when we see the median overall survivals with various molecules that are available from the first generation to third generation, second generation, so it ranges anywhere from 21 months to 34 months. The highest is being seen with decomatinib. But when you see the included population in the trials, based upon which we do actually base our practice, the brain mets were included in almost all the studies, which is a very common phenomenon in advanced lung cancer. But decomatinib is in the Archer 10150 trial, brain mets are effectively excluded from the trial itself, making it vulnerable for the comments of whether it is really effective against the brain metastasis or not. Next slide, please. One of the most important caveats of decomitinib overall survival Kaplan-Meier curve is that it is a hierarchical statistical model, which means that if A is greater than B, then only we can compare B with C. So that is the hierarchical model. So it should actually satisfy the first condition to check the second condition. However, decomitinib did not satisfy the first condition. That is, Archer 1050 started with a condition that only when there is a difference, statistically significant difference in the overall response rate, the OS benefit should be calculated. And it has failed to do so. There was no statistical significant difference between the overall response rate. So we cannot actually calculate the overall survival whether it is significant or not. So however good the value seems to be, but if we really talk about the real value, it is not significant. Next slide, please. Yeah. So one more comment that is commonly seen while discussing decomitinib is that there is a difference between the benefits that are seen in the PFS analysis as well as the overall survival analysis. In the PFS analysis, it is seen that the non-Asian population may not be benefited much, but in the OS analysis, it is seen that the trend is not seen, and both Asian and non-Asian population are seems to be not much benefited alike. So because both the lines are meeting the line of unity in the center. In the same way, we know that exon 19 is a favorable mutation biologically compared to exon 21 mutation, and so the PFS stand along those lines in Archer analysis, but in OS it is again reversed. So this unexplained flip between PFS and OS has been a matter of debate. Next slide, please. The other important aspect is about the tolerability profile of EGFR TKIs. We know that, as we have discussed, that epidermal growth factor receptor, it is very important to maintain the skin surface, mucosa, and as well as in the bone marrow, the proliferating cells. So the side effects also are according to these profiles. So when mucosa is affected, diarrhea is the class side effect. When skin is affected, rash and acne is the class side effect. When oral mucosa is affected, stomatitis and mucositis does occur. In the same way, for the maintenance of the hair, nails and mucosa. So the nails are also affected, and so paranoia. And in the bone marrow, it does cause neutropenia, although it is very, very rare. Almost it is negligible, we can say, the neutropenia. However, diarrhea, rash are significant side effects when we see first and second generation side effects. The highest amount of diarrhea and rash are seen with decomitinib, and we can see to the tune of diarrhea of 87% of any grade. And when we see grade 3 or 4, it is nearly 10%. That is, 1 in 10 patients does have severe diarrhea, which might need admission. And rash and acne are also of the similar percentage, and rash is much more common. Grade 3-4 is nearly 20% in decomitinib. And paranoia is again up to the tune of 10%, and if we see any grade of paranoia, it is nearly 60% of patients. So grade 3 adverse effects of MO are seen in nearly 37% of the patients, and adverse effects leading to discontinuation are seen in nearly 20%, which means 1 in 5 patients might need to discontinue or decrease the dose of the drug due to these side effects. Next slide, please. So this has been an unmet need, medical need in India in advanced mutation, advanced NSCLC with EGFR mutation. So then came the drug of osimertinib, where, however, the main challenge had been till now the higher cost. Although the company is providing a good patient assistance program with providing 20 days of free treatment with 10 days of treatment, but still, it is still an unmet medical need. Next slide, please. This slide has been very well discussed with by Dr. Neeti ma'am, so I will not go into details, but we do know that the FLARA trial, which has been evaluated by Dr. Suresh Ramalingam, where osimertinib is compared with the first generation TKI. But the most important points which we need to note here is that in the FLARA trial, patients with performance status of 0 and 1 has been included. There is no patient with performance status 2 or 3. But in the 3 trials that are discussed by Man, we can see the number of patients who are included with poor performance status, including PS2 and PS3. So the data does suggest that we can still use in those patients with poor performance status also. And it is not very uncommon phenomenon to give TKIs to rail tube when the patient is in a poor general condition and first time presented with a very poor general condition, and ultimately biopsy reveal EGFR mutation, and then we can even give with to the rail tube also, and we can see dramatic improvements occurring in some of the patients. Next slide, please. Although this trial has been very well discussed by and other speakers, now I'll touch upon only important points. The PFS benefit, we can see here, the HR ratio is nearly 0.48, particularly in the CNS subset, because CNS progression is a very important challenge, not only in unmutated lung cancer, but also in EGFR and all subset as well. So using a TKI that has a CNS penetration upfront is the most important factor. And we can see nearly 52% of the patients are being prevented in a CNS progression. So this is really something significant that actually inspires the physician to use our counsel for osimertinib whenever possible. Next slide, please. So final overall survival, we can see here, the HR ratio is nearly 0.8, which means there are 20% of patients that are prevented from the death when we use overall survival, when we use osimertinib upfront compared to the first generation TKI. And the difference in the overall median OS is nearly 9 months, which is almost equal to the PFS of the first generation TKI. Next slide, please. So one more important factor that was studied in the FLARA is the time for the subsequent treatment at death. That is quite prolonged with osimertinib compared to other comparator arm, that is first generation TKI. With osimertinib, we can see the number of events that occurred are only 194, while in the comparator form, in the same duration, 250 events have been occurred. Next slide, please. And this is one important slide which we want to focus upon, because although both sides, the side effects seems to be similar, when we see the grade 3-4 side effects that are included within these bar diagrams in a thicker fashion, we can see that diarrhea, rash, nail effects, dry skin, they are less than to the tune of only 1% in the osimertinib, compared to the nearly 7 to 8% in the opposite arm. The overall, when we see even the minute grade 1 effects also, they seem to be similar. That is, diarrhea is 60% versus 58%. But when we see the grade 3-4 side effects, which require admission or the dose modification, they are really, really less with osimertinib. And that is why it is a cool molecule both on patients as well as physicians. However, from the real world data, we have seen that there is a chance of pneumonitis, which we need to monitor. We need to avoid any concurrent medication that can cause lung injury. That is the reason why when we are using the costlier TKIs, it is very important to check drug interactions. And second is, we have seen the higher incidence of venous thromboembolism. And that is the reason why we need to examine the patient. Although the patient is TKI, they have no symptoms, it is important to examine the patient to see any DVT or venous thromboembolism as per the symptoms for the same. Next slide, please. And real world studies have been very well discussed. So I will end my, please go to the last slide, concluding slide, please. Last slide, please. Last but one slide. Next slide, please. So the unmet need of targeting EGFR mutation while the first generation, second generation, the TKI is being plateaued is osimertinib, and osimertinib monotherapy is still effective. And the strongest evidence is for osimertinib monotherapy in all European as well as NCCN guidelines. Moderate evidence is for those patients who may not be affording osimertinib. First generation TKI plus chemotherapy is the way to go. And in other patients with rare mutations, we can use second generation TKIs like afatinib. However, at this juncture in 2023, using only monotherapy with getinib or erlotinib is not recommended as such. So thank you Sumit sir again for giving this opportunity.
Thank you, Dr. Venkat. That was a wonderful presentation. You have taken us through the nuances of the receptors to the evidence that we have and the data that we have. So moving on from this wonderful talk to the next talk. The next talk is by Dr. Kapil Goyal. He's a consultant at Action Biology Hospital. Dr. Kapil Goyal will be taking us through the topic of decoding treatment options for EGFR mutated non-small cell lung cancer. So over to you, Dr. Kapil.
No. I hope my slides are visible.
Yeah, Dr. Kapil, your slides are visible and you are audible.
Okay, thank you.
Yes.
So I'll be talking about decoded treatment option for EGFR mutated NSCLC. So first talking about the symptom burden. So if worldwide data, if we look at the Globocan 2020 data, we see that this both sexes combined, lung cancer is the second most common diagnosed cancer, consisting about 11.4% of the total cases. But in terms of mortality, it has higher mortality, responsible for almost 18% of the total cancer deaths, because lung cancer in particular is a cancer causing mortality. So when we are deciding treatment choice for first-line treatment of advanced EGFR mutated NSCLC patients, we have to look for a few things like the available data, what is the progression-free survival, the overall survival, overall response rate of the given agent, presence of brain metastasis or not, what is the safety and toxicity according to the comorbidity profile of the patient, what is the quality of life we are going to offer to the patient, and whether patient is receiving any subsequent therapy upon progression. So if we talk about different TKIs, we have a first generation TKI like gefitinib and erlotinib, second generation afatinib, dacometinib, and third generation osimertinib. We see that the first generation TKI provided PFS benefit of 9.5 months with gefitinib and erlotinib 13.1 months, which were not aggressively improved with the second generation TKI like afatinib 11 months and dacometinib in Archer trial 14.7 months. While talking about this third generation osimertinib, we see that the median progression-free survival was 18.9 months, which were quite ahead compared to the previous generation TKIs. Here we see the Kaplan-Meier survival curve in the Lung 7 trial, which compared afatinib with the standard of care gefitinib arm. We see that the curves started separating after only 1 year of the therapy. Similarly, in Archer 1050 trial, we see the curves started separating after 6 months of the therapy. While in the Flora trial, the osimertinib and the standard of care erlotinib or gefitinib, the curves started separating right at the beginning, and it included the stable brain metastasis patient also, which constituted roughly 20% of the population. And in the Lux Lung trial, afatinib trial, the stable brain metastases were included, which were 16% of the total population, while in dacometinib trial, all brain metastases were excluded. Although we cannot make a definite conclusion based upon the cross-trial comparison, but it just gives us the rough idea that the osimertinib is effective starting from the treatment. If we talk about the overall response rate and the duration of response, if we see with the afatinib, the ORR was 70%, which was 75% with the dacometinib in Archer trial, and it was 80% in osimertinib, which was the highest. Talking about the duration of response, if you can see that it's with afatinib, it was 10 months, while it was 14.8, which is approximately 15 months with dacometinib, but it was 17.2 months with the osimertinib. So if we see that the overall response rate and as well as the duration of response was highest with osimertinib, although again bearing in mind that it is a cross-trial comparison and we should not be making any definite conclusion based on this finding. If we look at the survival curve of the FLORA, overall survival final analysis, the osimertinib arm had a median OS of 38.6 months compared with 31.8 months with erlotinib and geftinib, with a hazard ratio of 0.799, which was statistically significant. So it is the first time that an EGFR TKI has demonstrated a meaningful and statistically significant OS as well as PFS benefit. And the median OS was first time more than 3 years. If we look at the Kaplan-Meier survival curve, OS survival curve of Lux Lung 7 trial and Archer 1050 trial, we see that the OS benefit could not be demonstrated with afatinib compared to geftinib, while in dacometinib, although the curves seem to be separated, but because the trial design was like that, the hierarchical testing was done. If the ORR was not significantly improved with dacometinib, hence the overall survival was not formally statistically tested. So if in the FLORA trial, we see that at the end of 3 years, 28% patients were receiving osimertinib, which was great because in comparison, only 9% of the patients were receiving the treatment in the comparator arm. If we see in the brain metastasis, so in patient with brain metastasis or without brain metastasis, the osimertinib was effective. Median PFS was improved in patient with known metastasis, 15.2 months compared with 9.6 months, and hazard ratio was 0.47. While in patient who did not have CNS metastasis, the osimertinib provided hazard ratio benefit of 0.46, and both of them were statistically significant. And CNS progression event occurred in only 6% of the patient compared to 15% of the patient who were receiving osimertinib versus standard of care. If we see about the intracranial, the CNS PFS, there also we see that the median CNS PFS was not reached in the osimertinib arm, while in the comparator arm, it was 14 months with a hazard ratio of 0.48. So hence, we can confidently conclude that the CNS PFS was statistically better with osimertinib compared with the first-line TKIs. Here we have a CNS metastasis data of different TKIs. If we talk about the afatinib, we can see that CNS PFS was 8.2 months in the Lux Lung 36 trial, and it was 7.2 months in the Lux Lung 7 trial. In dacometinib, the brain metastasis patients were excluded, while in the FLORA trial, it was 15.2 months, so it was way ahead compared to afatinib in cases of CNS PFS, although again having a word of caution because the cross-trial comparison, so it cannot be taken as such. Talking about the safety, the adverse event of grade 3 to 4 in Archer 1050 trial, we see that the dacometinib in 63% of the patient had some kind of grade 3 to 4 adverse event, while grade 3 adverse event with afatinib was reported in the 31% of the patient in afatinib, while in the FLORA trial, only 18% of the patient had grade 3 or more adverse event. The most common adverse event were diarrhea and fatigue. So if we talk about the skin toxicity and the diarrhea, the afatinib was the most toxic, causing diarrhea 18% of the patient, while dacometinib caused skin toxicity in 14% of the patient. While we see the osimertinib is fairly well tolerated, causing grade 3 skin or toxicity or diarrhea or any kind of toxicity in only 1 to 2% of the patients. If we see the dose reduction which were required, so in Lux Lung 7 trial, the adverse event leading to dose reduction were frequent in the patient taking afatinib. Almost 42% of the patient required dose reduction, while with dacometinib, 67% patient required dose reduction, while in FLORA trial, only 5% of the patient required dose reduction. So hence, here the data speaks for itself that the osimertinib is very well tolerated and that there is very infrequent dose reduction required. Quality of life also, if we see in FLORA trial, the quality of life improved with the osimertinib as well as with the first generation TKIs. While in the Archer 1050 trial, quality of life was maintained. It was improved in some patients, but in many patients, it was deteriorated. Although this was not clinically, it was not statistically tested. So there is an argument that what if we start the patient on first generation TKI first line, and then when at time of progression we can add osimertinib at the time of progression. So here we see that 1/3 of the patient who are treated with the first or second generation EGFR TKI are able to receive second line osimertinib, because suppose we starting with the 10 patient as an example who are started on geftinib or erlotinib or afatinib, approximately 30% patient die during the first line treatment, or they receive only palliative care upon progression due to the poor PS. Of the remaining 75% of the patients, only 60 to 75% of the patients receive a validated T790M test result, and many and other patients are not eligible for the tissue biopsy, do not have any good quality tissue available, or lost to follow up, or the financial issues, or get a false negative liquid biopsy test, so they do not get a reliable biopsy result. Even in those patients who get a good T790M test, only 50% of those are actually T790M positive, who are able to get osimertinib in their second line, and rest of them are T790M negative. Comprising of all three, we see out of the 10 patients, only 3 patients are able to get osimertinib in their second line. Hence, it is important that we give the benefit of osimertinib in the first line itself. There is another study which showed that the subsequent treatment was available only to 70 to 80% of across trials. If you can see in the geftinib trials, the erlotinib trials, the afatinib trials, only roughly 60 to 70% of the patients were able to receive the osim subsequent treatment. So approximately 1/3 of the patient will not have access to any second line treatment. Hence, it's important that we give osimertinib in the first line itself. There is some real-world evidence of T790M mutation after afatinib. In the Japanese study, we see that patients who were given afatinib in the first-line setting, 43% of the patient had T790M mutation. In another Taiwanese study, only 48% of the patient had T790M mutation. And in another study, only 32% of the patient. The meaning being that half of the patients will not have T790M mutation, and then they will not be eligible for osimertinib therapy, and we will have to shift them to the chemotherapy. So less than 50% of the patient acquire T790M mutation and hence are eligible for osimertinib. So correct sequencing of EGFR TKIs, we see that starting with prior generation EGFR TKI and then treating those that develop EGFR T790M mutation with osimertinib is not an optimal clinical care, because of course we do not know which patient will get EGFR T790M mutation or not, because as discussed earlier, only up to 40 to 45% of the patient have T790M mutation upon progression. And then many of these patients will have poor PS and they will not be eligible for any subsequent osimertinib therapy. And many patients, we do not have the fresh tissue and liquid biopsy available to comment upon the mutation status. And osimertinib in the first line itself has shown a magnificent survival benefit. Hence, it's important that the osimertinib is started in the first line itself. And then there are many uncontrollable factors in the EGFR TKI sequencing related, like toxicity to the drug. If we have severe toxicity in the first line itself, the patient might not be eligible for second line osimertinib. Occurrence of T790M mutation, as I already talked about, only 40 to 50% patients have this mutation. Sites of progression, concurrent morbidity may occlude, and the patient choice. So we have a few real-world studies with the first-line osimertinib. Here I'm discussing about the FLOWER study, which is first-line osimertinib in the real world. An inter-regional prospective study. It was conducted in Italy across 9 centers with a sample size of 126, in which osimertinib was given to the EGFR mutated NSCLC patients in the metastatic or advanced cases. All the patients were white, and squamous cell carcinoma were the histology in 3 patients. Approximately 13% patient had poor PS and 30% patient had brain metastasis at the baseline. So time to treatment discontinuation was 25.3 months and the progression-free survival was 18.9 months, which is equivalent to as demonstrated in the FLORA trial. The median time to discontinuation in patient with or without symptom at diagnosis, we see in patient who did not have any symptom at the diagnosis, the median TTD was not reached, while it was 18.8 months in those who had symptoms. And in patients who had less than 3 metastasis site, in those also the median MTTD was not reached, while it was 21.4 months who had more than 3 metastatic sites. Talking about the patients who had brain metastasis, the median PFS was 13.3 months, which is lesser than the average, and it was not reached in patient who did not have any brain metastasis. And accordingly, similarly, the patient who had any symptom at the diagnosis, the median PFS of 15.5 months, and it was not reached in the patient who did not have any symptom. So conclusively, we can say that this study, the data and the efficacy data and the safety data, it matches as per seen in the FLORA trial. 73% of the patient achieved PR, while 23% of the patient achieved stable disease. In 50% of the patient, the mutation was exon 19 deletion, while it was exon 21 L858R mutation in 43% of the patient. So we can say that the osimertinib data was similar to as seen in the FLORA data. The median time from biopsy to pathological report was 7 days, which almost we are also able to achieve in our routine day-to-day practice. And from pathological report to EGFR mutation status from to EGFR mutation for 8 days. And the EGFR mutation status report to osimertinib start was 17 days. This delay was a little higher than expected. And 47.7% of the patient underwent a repeat biopsy at the time of progression, which was in 2/3 of the cases, it was a tissue biopsy, while approximately 1/3 of the patient underwent a liquid biopsy. And the molecular analysis was performed in 62% of the cases. There were 13 samples. So the druggable resistance mechanism was found in a few, in which the MET amplification was the most common, seen in 4 cases, while MET amplification and EGFR amplification was seen in 1 case, and HER2/neu amplification was seen in 1 case. The most common adverse event were 38.9% patient had diarrhea and 33% patient had skin rashes. The point to note here is that the venous thromboembolism was seen in 9.5% of the cases, which was surprising because in FLORA trial, only approximately 1% patient had venous thromboembolism. Although according to age, PS, comorbidity, tumor load, the incidence of VTE was not different. So we have to, while giving osimertinib, we have to keep this possibility of venous thromboembolism in mind, and we have to deal with it accordingly. So osimertinib has confirmed effectiveness and safety in the real world, although thromboembolism were more frequent than previously reported. Then osimertinib as first-line treatment for advanced EGFR mutated positive NSCLC. So we have a retrospective study coming from Japan, in which a large number of patients, the sample size of 538, were given osimertinib in the first line. The median age was 71 years, which is older population, and 98% patient had adenocarcinoma. The PS2 or more than 2 was there in 16% of the patient, and brain metastasis were there in the 31 patient at the baseline. Here, if we see the median PFS was 20.5 months and the median TTF was 19.1 months, which is similar to what was seen in the FLORA trial. So in the real world in Japan also, the efficacy of osimertinib was similar to the trial population. The interesting point to note here is that when, according to the mutation status, if we see the approximately 50% patient had exon 19 deletion, and similar 45% patient had exon 21 deletion, but there was some treatment response differentiation. If we see that the patient who had exon 19 deletion had better survival compared to those who had L858R mutation, although the survival curve seemed to merge in the end, but for some good 1 year and 1.5 years, there was a difference. The exact reason is not known. Similarly, if we see according to the PD-L1 status, here the data becomes very interesting. We see that this the patient in which the PD-L1 expression was more than 50%, they were doing worse compared to the patient who had PD-L1 TPS less than 1%, they were doing better. So in short, the patient who have less PD-L1 expression, they are doing better on the osimertinib, and for patient who have PD-L1 expression more than 50%, they were doing worse. So if we talk about the toxicity, pneumonitis is the thing which is to be talked about in this data. The pneumonitis all grade was seen in approximately 13% of the patient, which is way lot compared to what was seen in the FLORA trial. The non-hematological toxicity of grade 3 was seen in 13% of the patients. The median time from the start of treatment to the onset of adverse event was 56 days. So roughly approximately after 2 months of the starting therapy, we have to start looking for adverse events. The pneumonitis occurred in 13% of the patient, while it was grade 3 or more than that in 5% of the patient, and in 4 patients it was fatal. The reason for discontinuation treatment was highest. The 44% of the patient discontinued the treatment because of the disease progression, while 1/4 of the patient had to discontinue osimertinib due to pneumonitis. So it was very shocking, because in our practice also, and I think my other colleagues will concur, that the pneumonitis incidence with osimertinib is not that common in Indian patients. So why it was happening so in the Japanese patient, that we have to see. The PFS after first-line osimertinib treatment in the real-world practice was favorable. The discontinuation rate due to adverse event, especially pneumonitis, requires further investigation because it has not been seen in other populations. Then we have MICNOS, which is a real-world study of patients with EGFR mutated locally advanced or metastatic NSCLC treated with first-line osimertinib. So it was a global observational cohort study, including data from USA, Japan, Germany, and China. So the patient received first-line osimertinib. The median age was 70 years. The sample size was 541, and 15% of the patient had PS2 or poorer. 33% patient had brain metastasis, and comorbidity index was more than 3 in 5.7% of the patient. Here also, if we see that 51% of the patient had exon 19 deletion, while only 1/3 patient had exon 21 L858R mutation. Interesting. So at this, based on first data cut analysis of the US subpopulation, we see that the 58% of the patient remained on first-line osimertinib therapy or were lost to follow-up. And 18.8% patient received any second line of treatment, including immunotherapy or combination therapies, and 18.4% patient have died on the first-line treatment itself. The median time to next treatment or death was 17.9 months, while median time to treatment discontinuation was 17.2 months, which is fairly as was seen in the FLORA trial. So this interim real-world data supports the effectiveness of osimertinib in the real-world population. Longer-term outcome will be evaluated in the final analysis, which is still awaited. So let's talk about what the guidelines are saying regarding the use of osimertinib. So here we have NCCN guidelines in which EGFR exon 19 deletion or L858R mutation study. If it is the mutation report is available when the patient is still treatment naive, the category 1 indication is osimertinib, and it is a preferred therapy. Although erlotinib or afatinib, geftinib can be used, they are also category 1 indication, but they are not the preferred ones because of the reasons I discussed earlier. Although if the financial constraints are there, then definitely we can use any first generation TKI as well. While if the EGFR mutation is discovered because of the symptoms, suppose we are not able to get the EGFR report in time, or if because of the symptom we have to start on cytotoxic chemotherapy upfront and EGFR mutation is detected later on, that it is recommended that we have to complete planned systemic therapy first, including the maintenance therapy, or we can just interrupt the treatment and then, or we can interrupt at the maintenance part, and then we can start on the osimertinib, which is a preferred strategy. Although if osimertinib is not available, then of course we can go for erlotinib, afatinib, or geftinib. On the progression, the second line treatment has to be given. Here we have the ESCO living guidelines in which patients with stage 4 NSCLC with non-squamous cell carcinoma, any sensitizing mutation, the osimertinib monotherapy is recommended, which has a very strong level of recommendation. For moderate level of recommendation, we can use geftinib with doublet chemotherapy. The data is very exciting. We had a trial from Tata Memorial about this. Other options are dacomitinib monotherapy or afatinib monotherapy. Other weaker combinations are erlotinib with ramucirumab or bevacizumab. Or the weak recommendation, monotherapy with osimertinib, geftinib, or erlotinib combinations, and the first line treatment options. So to summarize, osimertinib is the only EGFR TKI which has demonstrated a clinically meaningful and statistically significant improvement in the overall survival. The median OS benefit of greater than 3 years sets a new benchmark for osimertinib, because previously we have not been able to go beyond 2 years or 2.5 years. It provides a window of opportunity for the management of patient with stage 4 NSCLC with sensitizing mutation. FLORA is the first time that an EGFR TKI has translated PFS into an OS benefit, and nearly 30% of the patients are still on osimertinib after 3 years. And it is the only drug which is effective in patients with brain metastasis and who have T790M mutations as well. Talking about the safety, it is the safest and the least toxic drug with the least discontinuation rates and the least number of grade 3 and 4 toxicities. And the EGFR TKI sequencing is not the best therapy as far as possible. We must consider giving osimertinib in the first line therapy, as we have already seen that only 3 out of the 10 patients are able to receive osimertinib in the second line. So osimertinib is the first line standard of care in the metastatic EGFR mutated NSCLC. This session was sponsored by AstraZeneca, and thank you. Any questions are welcome.
Thank you, Dr. Kapil, for that wonderful presentation and taking us through the journey of TKIs in lung cancer from first generation to second generation to third generation, and again highlighting the importance of real world data. As you rightly said,
Right.
it is the least toxic medicine with most, and it is the most effective medicine with least side effects. So we all agree it is a good medicine, and our everyone's learning experience have been very good with this medicine, and we are real confident in using this medicine now. So with this, I think we don't have any further questions. I thank the organizers. I thank Intas. I thank Zymera Biosciences and AstraZeneca for giving us
Sir, I
this
have a
platform.
small.
Yeah,
I
yeah.
just wanted your input that the real world data that I talked about, they say that many patients had venous thromboembolism or the pneumonitis. What is your experience? Have you
No.
seen any? I have
See,
not seen any case developing
yeah,
pneumonitis.
exactly. That Dr. Niti Madam also highlighted in the series that there is an increased incidence of venous thromboembolism. But so far, we are lucky to not have seen this side effect. I don't think it is that common because whosoever we talk to, none of them have said openly, yes, it has happened with them. So maybe someday we will see, but that is true for any other medicine. But so far, we have been lucky. I've not seen VTE with this. Maybe borderline QTC I've seen, but not this.
So,
So, Dr. Venkat, your experience? Niti ma'am is not there, I think.
Sir, I have very few patients over the osimertinib, but the tolerance is really good, sir. So out
Yes.
of 5 patients on osimertinib, one is a squamous cell carcinoma. They're doing good, sir. As of now, only one patient has a slight QT prolongation, but I have continued and it was all right, sir. So
Okay. Okay. Yeah, that is everyone's observation also. So, with this, I thank our esteemed speakers, Dr. Sunil Pasricha, for giving us wonderful insights into the pathology and the way forward with the molecular testing. Then Dr. Niti Madam for taking us through the real world data, and Dr. Venkat Babu for a wonderful presentation and so in a very lucid manner and in very brief view. Definitely it was enlightening and refreshing all the nuances. And Dr. Kapil for taking us through the treatment options from the beginning, first generation, second generation, till the end, and comparing it with the real world data. In the end, I thank you all and the organizers, the Horizons, for giving us this opportunity and platform. Thank you very much for your kind time and consideration. Thank you.
thank you, sir.
Over to you if you have any
Thank
final
you.
comments. Okay, then we stop here. Thank you very much. Good night.